a client standpoint, our clients still have strong interest. In fact, we still are acquiring clients related to COVID-19, not losing them. So there's still lots of questions and hopefully lots of answers we can provide. So I'm going to turn it to Dr. Lankau, who's going to give us a bit of a situation update, and then we'll talk about a number of issues as we go on. Emily?
Thanks, Til. Next slide, please. So we try with clients to use good communication practices, and we start up front with our key takeaways. So these are the messages that we would like you to take and then to take into your communities. While things are getting better, case rates are still very, very high, and we still need to use all our mitigation strategies according to CDC guidance. Vaccines have prevented severe illness and death for many, many, many people. So please get vaccinated, receive your boosters as recommended, and encourage folks who are hesitant to consider getting vaccinated. The healthcare system is recovering from an enormous stress, both physical and mental, and we really do need to prioritize our families' physical and mental health to keep ourselves out of that emergency system so that hospital beds are available for folks who are still recovering from COVID-19 and other illnesses. And finally, we are not out of the woods yet. So please do be patient, continue to use mitigation strategies, and be cautious until we get to lower case rates. Next slide, please. We know that COVID-19 remains a global challenge, and to give you a visual of that, we've given you February 12th, 2021 in the upper corner. That's on exactly the same scale as the current map from February 12th, 2022. And we can see that there is a large amount of virus transmission going on globally, particularly in parts of Europe, the United States, and parts of South America. Australia is also getting hit pretty hard now compared to where they were this time last year. So we know there's a lot of virus transmission happening around the globe, and countries across the globe are struggling with what to do and how to manage COVID-19 as we continue to see cases. I'm going to show you some international data that demonstrate that different countries are dealing with this differently, partially because their situations are very different from the United States. Next slide, please. This pandemic wave may have crested globally, so we are seeing most places in the world have hit a peak and are starting to decline. But these big continental pictures disguise the fact that different countries within those areas are very variable, and that's particularly true in Europe. We have seen that there are declines happening, but I want you to note, compared to February 12th of 2021, we are still seeing case rates that are much higher than where we were this time last year. And for some locations, we're still at case rates that are higher than where we were at the peak of this last wave that happened in February and January of 2021. So while things are improving, we need to proceed with caution because we are not there yet. Next slide, please. I want to dig down a little bit into how we compare to other countries that are sort of at our socioeconomic level and size, although not quite as big as we are, but places in Europe that we tend to compare ourselves to, that we tend to track, like Denmark, Portugal, France, Germany, the United Kingdom. And what we're seeing is, while most countries, with Denmark being the exception, particularly because of the BA2 variant, subvariant, we're seeing declines across Europe. We really have to be cautious in following Europe's lead. So Europe has generally started to reopen, to remove restrictions. And part of the reason that they've been doing that is because they are in a slightly different situation than we are. While they're seeing high case rates, they are not seeing the hospitalization numbers that we're seeing in the United States. And the little arrow in the lower right points you to one of the big reasons for that. Compared to other countries that we tend to track in terms of our demographics and our population and how our outbreak has proceeded, we have much lower vaccination rates and particularly lower booster rates. So while we are seeing places like Denmark with high case rates proceeding with reopening, they're doing that with a much higher level of protection against hospitalization and death. In the United States, the situation is different from most of our European colleagues that are doing a lot of reopening and removing restrictions at this time. Next slide, please. I like this quote that came out of the article that's cited at the bottom. If we want to declare the end of the pandemic right now, what we're doing is normalizing a very high rate of death. And we do need to be aware that while the United States is having high case rates, we're also still having high hospitalizations and deaths. And that is very different and has been different from our European colleagues across the globe for the entire course of this outbreak. There are many differences in the United States that have contributed to these death rates, and a big piece of that is our vaccination rates, but also our demographics and our access to healthcare resources in rural areas have played a big role in this as well. So our share of population fully vaccinated is lower than most other comparable countries, and our cumulative deaths throughout this pandemic has been higher, and those two factors do tend to correlate. Next slide, please. I think we've used this slide in multiple town halls now. We are at the same place that we were this time last year. We have three big barriers to controlling COVID-19. Variants have played a huge role. While things were somewhat under control over the summer, with the emergence of Omicron, we have seen big shifts in the numbers of cases that we're seeing across the country. And our case rates are much higher now than they were this time last year. We also have difficulties with variability in vaccine uptake. This map shows you at a state level that we have some states that are at much higher uptake than others. When we drill down within a state, we also see that within highly vaccinated states, there are counties even within those states that are still not protected as much as we would like to see. The final factor that has been a real struggle is changes in behavior. And we have sort of moved to reopening prematurely and have removed mask restrictions, removed physical distancing restrictions, and have opened the door to a lot more virus transmission than we would like to be seeing. Next slide, please. So right now, this map or this figure shows you a map from February of 2021 and February of 2022. Dark colors mean higher case rates, and you can see that we are still seeing enormous amounts of virus transmission across our country. That is even worse than where we were this time last year. Next slide, please. What we know is that vaccinated people have a much lower risk of infection and a substantially lower risk of dying from COVID-19. So even at these very high case rates, we are fortunate to have a good portion of the population, about 2/3, protected through vaccination and boostering. You can see on the figure on the left that when we look at cases over the past few months, while we see a pretty big uptick in cases in our unvaccinated population, we see a smaller degree of uptick in our fully vaccinated and boosted. And CDC estimates that unvaccinated people have about 3 times the risk of infection from the month of December compared to vaccinated people, and 5 times the risk of becoming infected compared to our boosted populations. We see a similar pattern with deaths in that unvaccinated people have a much higher risk of hospitalization and death if they are not, vaccinated and are exposed to COVID-19. And that is 15 times the risk compared to fully vaccinated people and 68 times the risk compared to boosted. We know vaccines have made an enormous difference and have prevented a number of deaths. Next slide, please. Oop, go back just one. There. Oh, forward one more. We're skipping one for some reason. It's okay. So we know that 1 in 3 people, however, are not fully vaccinated. And this is something that is of high concern. Because we have lower vaccination rates, we're seeing much higher hospitalizations, and those hospitalizations are still translating to severe illness and death, despite the fact that we have access to effective vaccines. This figure shows you that while vaccine uptake has been quite high in our older population who are at the most severe risk of death, we're not seeing that level of uptake in our younger populations yet. While some of that is understandable, our youngest populations were just released to vaccination in January. We're still seeing very slow uptake in our 5 to 11-year-old population, and not as much uptake as we'd like to see in our 12 to 17-year-olds. While children very rarely get severe disease and very rarely die, they do play an important role in the transmission of this virus. And so getting kids vaccinated protects them from those rare but very serious outcomes. And it also protects us by reducing the amount of virus transmission that we see in households. So it's important that kids get vaccinated. Parents across the board, across the political spectrum, have been much more concerned about vaccines in younger kids and are weighing those cost benefits. And I want to reiterate that public health experts really do recommend that we get kids vaccinated, both to protect them from severe outcomes and to protect their families and friends and people they interact with from transmission. Next slide, please. There's our hospital slide. So one of the challenges with Omicron is that we do have some indication that Omicron may be less severe in the disease that it causes. And also because we have so much vaccination, we do have 2/3 of the population protected. It causes less severe disease overall across the population because of that onboard and prevention of severe disease. We're still seeing 3 and 4 hospitals under high or extreme stress as of last week with the volume of patients that they're receiving who are infected with COVID-19, along with other respiratory viruses that are common this time of year. So you can compare the 2 boxes that I've highlighted for you of this time last year and this time this year, and you can see that 3 out of 4 hospitals are currently really struggling with high patient volume. Now, the good news is as case rates come down, we are also seeing hospitalizations go down. So we should see some relief on hospitals shortly. But we have to remember that we're going to continue to see deaths accumulating for a number of weeks still because it takes time for folks to become ill, to spend time in the hospital, and then eventually, unfortunately, die. And so we're not going to see those death rates drop for another couple of weeks as we come out of this wave. So we need to be aware that people are still very sick and hospitals are working very hard to try to save lives. Next slide, please. So the big takeaway right now, and this map shows you where we are, is that according to CDC's guidance, we should be wearing masks in public settings, when we're indoors, and in crowded settings in general, when we're in close proximity to others, when we're in that substantial, the orange or the high, the red categories. And right now, we are seeing a lot of community transmission across the United States, and basically all counties are recommended for use of masks. Now, in contrast to that recommendation and where we are on the case rates, we're seeing a number of mask requirements being dropped across the country. Folks are responding to the lowering case rates by removing restrictions and trying to move forward with reopening. And this may be premature. While it's happening in Europe for reasons that we've talked about, where in Europe we're not seeing the high hospitalizations that we're seeing in the United States, our situation is different, and I think we still need to be quite cautious and follow CDC guidance and wear masks whether they're required or not, because right now we need to be working to reduce transmission and keep folks out of the hospital so that the hospitals can catch up from this enormous load. Next slide, please. So again, we like to repeat our messaging for clients. We do it for you as well. We are not powerless, and individual decisions still matter in this outbreak. We are not through the pandemic yet, although we are hopeful that things are improving. We have vaccines that work, and we need to use all the tools to get this under control to save lives. So please do get vaccinated and encourage hesitant relatives and friends to do so as well. Use masking, physical distancing, and hand washing when we are at these high case rates. Prioritize your family's physical and mental health. Keep yourself out of emergency services if you can. And please be patient and remain vigilant. While we see these reopenings happening across the globe and we want to join in that and we want to get back to normal, we're not there yet. And the decisions that we make matter for the people we have interactions with who may or may not be protected or who may be immunocompromised, and even if they're vaccinated, may be at very high risk. So we can still protect the people around us by following these simple precautions. Next slide, please. And I'm going to pass this now to Dr. Jolly.
Thank you, Dr. Lankau, and thanks everybody. I'm going to just make a few key points, some of which Emily has made quite well, better than I could. And then we'll talk a bit about the internal Aveshka policies, and then there are a number of questions popping up that we as a group will be happy to take. There really are a number of important issues, and to kind of frame this a bit for you, I don't have a lot of other slides. This is a sort of a framing slide for what I'm going to discuss. We've been at this for over 2 years now, and we as a team, and I think all of us as individuals, recognize the importance of society getting restarted, the economy getting restarted, social activities, social interactions, school kids, and the like, sort of getting back to whatever normal is, and that's very important. And there's a way to do that safely. But we also focus on the data that you've seen from Emily, and some very important things to remember about that data that you saw is that first, the baseline that we see right now is still much higher than many other times during this pandemic. So numbers of cases that we at any other time would have considered unacceptable seem okay to people because the numbers are dropping, but they're still very large. And we've had 900,000 Americans die, and one can argue overcounting, undercounting in one way or another, and I've seen discussions in the press about that. That number is pretty good, and unfortunately, that are pretty accurate and pretty close. And that's a devastating effect on our country that we're not going to get back. And we're losing still nearly 200,000, nearly 2,000 people a day, which is a stunning number to consider at a time when much of the nation is going back to sort of interacting in a normal way. We're seeing public events getting back, and that's very important for the economy and for society. Both the large events like last night and the smaller events in local areas with restaurants and local businesses opening back up, and that's very important for the economy. But there's a safe way to do that. And so the basic things still work: masks, vaccination, and avoiding places when one is sick or symptomatic are very important, and then being tested when possible and when necessary. And those things are still the basics, they still work. The hospital system effects are real. We've talked about this before, the effects on hospital staffing and those that have left the medical profession, nursing, respiratory therapy, and otherwise, due to COVID. There are other variants on the horizon, perhaps. You've heard about BA2. We don't know what's happening in Denmark, but there's clearly something happening in Denmark with their numbers sort of out of proportion to all of ours. Now, Denmark does a very good job of tracking things. That may be part of it, but it's something worth watching. There's a little bit of a question about long COVID, and we can talk a little bit more about this. Long COVID is a tough one because we know it exists. It's a difficult definition because, as we've talked about in other sessions, it's a multifactorial illness. There are neurologic effects, there are cardiac effects, there are effects on kids, and there are effects on people who were not that sick to start with, who were not the sickest of the COVID patients, but have long-term effects, and that's real, and that's going to have effects internal to workforces, to schools, and to other places. And just one more word about vaccines and boosters. The numbers that Emily showed are actually quite disappointing from the United States perspective. We are well behind other nations in getting our population vaccinated and boosted, and that's going to continue to have deleterious effects for how we respond to this continued public health crisis. Lots of things are good now, but lots of things we still need to consider and be careful about and be smart about, and we can certainly do that.
Go ahead and start the question and answer portion of the program here. So I will just start with some of the questions that are in the chat for you, Til and Emily. So since our youngest populations are deemed not as affected, do you suggest children in this age group, healthy, no pre-existing conditions or health complications, continue to get boosters?
The short answer is yes. The slightly longer answer is that it's certainly consistent with CDC recommendations at age 12. And that may, of course, advance over time as we learn more about this. And as Emily pointed out, this is, yes, this disease appears to have less effect on children, but it doesn't have no effect on children. Sorry, that was a double negative, but it doesn't have no effect on children. There are some, unfortunately, very sick kids, so the kids are being protected. And as importantly, or most importantly, kids are very efficient transmitters of viruses. We know this. This is not news to any parent. And so schools are a great place for viruses to be transmitted. So even if those kids aren't particularly getting sick sometimes in a community, those kids mixing are very good at transmitting things to those who are more at risk. So yes, very, very consistent with established guidelines, which will probably expand over time, to be honest.
And then I know you touched upon this earlier about discussing long haul COVID, but who is at risk for this?
Yeah, unfortunately, anybody who gets COVID is at risk, and that's part of the problem. It would be, I don't know that we would like any circumstance but for this, but it would be easier if it were a certain population, if it were a certain age group or certain disease categories. But it really is, it's kind of a hit or miss thing. It's among children who are quite healthy, among young adults who are quite healthy, people that really don't get that sick, and it manifests itself as very different symptoms. It's people talk about COVID fog and sort of the neurologic problems, the memory problems they have with that, the task function problems they have with that. There are clear cardiac effects. There are long-term cardiac effects for COVID. It's for some significance, actually. Certainly long-term pulmonary effects. You hear about lots of people who have long-term shortness of breath and difficulty with exercise. And there are multiple academic centers that have stood up large-scale operations to manage these populations with a multidisciplinary team. So we're learning more about this. I wish I could say it's X% of Y people. Nobody really knows that unless Emily suddenly has come up with that data. So.
Okay. Nothing from you, Emily? No light at the end there?
No, there have been some studies that sort of demonstrate a more severe course of illness tends to correlate with, a longer recovery and potentially long COVID. But in terms of predicting who's going to experience that, it's very complicated. We haven't seen good studies to tell us who's going to be affected, and we haven't seen a good case definition of what long COVID is so that we can really define how common this is.
Okay, thank you. So for example, in Virginia, there are no mask mandates in schools. Have we seen any sort of increase in cases within the school age population?
Emily, any thoughts on that?
Well, so because case rates have been so high, we have seen a lot of places not able to keep up with contact tracing. So the truth is, I don't know that we know. We do know that, children can be infected. We know they transmit it readily in the household. And we don't have a good sense of what's been happening out there in the most recent environment because honestly, states have been struggling to keep up. We've seen a lot of reporting issues from states just keeping up with reporting cases, let alone contact tracing. So I don't think we know. I think we do know that masks are effective at reducing the spread of respiratory infections. And at this time of year, there are multiple that children are susceptible to. So masks are certainly recommended and are helpful for reducing the number of kids that are sick from not only COVID, but also flu, RSV. We've seen issues with all of these viruses. So whether or not it's mandated, it is strongly recommended while case rates are this high that children and adults wear masks when they're in close proximity to one another. Now, I know socially that's very hard, right? If the school's not requiring it, it's going to be tough to get kids to do it when no one else is doing it. So we all really need to come together on this and encourage mask wearing when in public settings, regardless of whether it's school or church or other public events, because they're effective. And even vaccinated people can become infected and can be part of that chain of transmission that could end with someone who dies. And so it is important that we try to prevent that.
Thank you. So someone typed in, I heard that boosters many of us have received are 40% affected and we may need another booster. Any thoughts?
Yeah, this is something we've talked about, and I think multiple of us predicted this in one way or another over time. This is not a surprise. This is how some vaccines work. So the data is coming out about some of the boosters and the waning effectiveness as measured by antibody responses over a period of time, whether it's 4 months, 5 months, 6 months. And it's not like there's an on-off switch. It's a gradual thing. And it probably depends on the individual. Some individuals have very strong immune systems and very strong immune responses and may last longer. And those with lesser immune responses, either because of illnesses they have or things that we do to them as medical professionals, are going to not last as long. And so, is there going to be another booster after the current booster? Entirely likely. This has been entirely likely from the time vaccines started. And it won't be a surprise. And so that I think we can anticipate that. I don't think it's a bad thing. It's not a failure. It's sort of a manifestation of how vaccines work over time.
Okay. And just piggybacking on this, do you think we'll continuously need to get this every so months? And do we anticipate just this becoming like, hey, once a year type thing? Do we not have any insight on that?
It may well be. I would not be surprised at all if it's every year or every 18 months. I mean, logistically, it becomes tough to remind people of things, but we all can remember to get other things. And so the public messaging is going to be very important, and public understanding of this will be very important. But as we've seen with the current boosters and the virus's ability to change, we're not going to get rid of this virus. If we were going to get rid of the virus, like smallpox, it's not a great perfect example, but we don't get smallpox vaccinations anymore because smallpox is gone. It's one of the great public health triumphs of the 20th century. But this one's not going to be gone. Nobody thinks that, and it is going to change. And so it's entirely likely that boosters will be needed.
And if somebody gets COVID, does that mean they have been exposed to the virus and will not get infected as new variants develop?
It certainly means they've been exposed, and it would be irresponsible of us to say that they have no immune advantage from being infected. We know that they develop some immune response from being infected. The problem with that immune response is that it's inconsistent and likely not as good as an vaccinated response. And the two together are really much better. They do get some immunity because the body develops that as a natural response to being exposed to the virus. The problem is that that immunity may not be effective against variants. First, they can become reinfected with the same variant a little bit, but probably not get as sick. But the new variants, you're only going to have partial immunity to at best.
Somebody asked you know if there's a place in the DMV where one can get help with long COVID?
Uh, that's a good question. I actually don't know the answer to that, but I'm going to take that back, and I'll get back to you with an answer. I have, it's just not something I've heard about. You can imagine, in any, and this is, I'm answering a DMV question from somebody in the DMV to somebody in the DMV, but you can't, not everybody wants to fly to Dulles to go to a clinic. So wherever you happen to be, I recognize that many of you aren't locally. Probably the first place to check would be a local major academic center, university of whatever it is that's got a medical school and residency programs. Wherever you happen to be, that's the most likely place to start looking, whether it's on the West Coast or the Midwest or in the Northeast or wherever. And I will ask around. I can imagine whether it be the Hopkins system or the MedStar system or maybe UVA or the University of Maryland system or maybe the Inova system. I'll check and I'll get back.
Thank you. And then a number of companies and agencies have announced plans to return to their offices in March. What are your thoughts on this?
Well, it's an interesting question. We deal with this. We see this in the press, and we see this among our clients, and everybody kind of wants to go back. And I think there's a way to go back intelligently, and it kind of depends on what you do and how critical it is. We have agencies that even during the worst of this months ago, although this one could argue that parts of this are the worst of it now, had to do enforcement actions that could only be done face to face, and that that we figured out a way that they could do that. I think it's really a bit of a case by case question. It really depends on local data, and it really means looking at the data that Emily has shown and saying, okay, in the local area, including the area from which people commute, what's the real status, and can we do this safely, or can we put it off, or can we have a limited set of folks?
There was an ad during the Super Bowl for qhealth.com at home COVID testing IoT device. Did you have any thoughts or information on its effectiveness?
I don't have specifics on that one. I was watching the game. I'm not sure I caught that. Emily, I don't know if you have thoughts on that one particularly.
I haven't looked at it.
Till, Greg is on the call. He's talked with Q.
Okay, Greg, if you're there, perhaps you could weigh in on Q and other related testing questions.
Sure. Q is a device that's point of care testing. It was one of the earliest FDA approved for non-clinical personnel to use. So it's been out there, at least 16, 18 months since their EUA. We were involved with Q and recommended them to be used as part of our client engagement with LA schools back when we were doing work for them. It is an elegant device. It is a molecular test, so it's highly specific and highly sensitive, arguably on par with lab tests. So from that standpoint, it's very good. The issue with Q has always been that it's not cheap. It requires a singular device that you plug in, then requires that you buy separate cartridges into which you place the swab that you take the sample from in your nose into the cartridge, which goes into the device, which then gives you a reading. But it is incredibly accurate. I know their pricing for our commercial clients, because we actually have a commercial client that is using it and who's very happy with it, but it runs close to $85 a test for them. So something that always factors into everybody's consideration of testing. But to your question, it's good. It's very accurate.
Thank you, Greg. Okay, so I asked this question personally, but if everyone in a family contracts COVID, one member doesn't test positive or display symptoms, is it likely to assume that they had it or that they're just lucky and didn't get it, considering how COVID is so highly transmissible, at least the Omicron variant?
So let me state that a little bit, and then Emily may have thoughts on this too. I mean, this is if it kind of walks like a duck and quacks like a duck, it's probably a duck. If the family is sick, we know how it transmits around. And if particularly somebody who's symptomatic, tests negative in a group that everybody else tested positive, it may well be a false negative because of technique of testing or something. A crowd of people that have COVID, the crowd's likely to all have COVID. Emily, have thoughts on that?
So certainly from a prevention standpoint, if one person in the family is positive, the whole family should be quarantining until everyone is cleared. So it's very likely, but we see a lot of variability in infection susceptibility and also how sick and how long people are sick. And so it's very easy to miss that testing window and potentially not test everyone positive. Particularly as we move from variant to variant, we've seen a shift in when we should be testing for Omicron relative to Delta. It seems to be a little earlier. People tend to spike and then come out of their viral shedding much more quickly. So it's very possible that everyone in the family had it. That said, if anyone in the family is not vaccinated, they should still get vaccinated and not just rely on natural immunity, because we don't know for certain how strong their response was, particularly if they didn't test positive. So we don't know for certain they had it. So from a prevention standpoint, assume everyone has it. From a vaccination standpoint, please get vaccinated and don't assume you have natural immunity just because the family was sick.
Thank you. Do you think over the next few years, businesses and schools, as examples, will have to be prepared to have employees or their students go back to remote work at times of higher infection rates?
I certainly do. Others may have thoughts on this, but I think first, this is as we've said on other calls, the schools, particularly closing for infectious disease outbreaks, is not an entirely new phenomenon. This didn't just happen with COVID. You may not have noticed if you didn't have school kids or weren't paying attention to this, but this has happened for flu outbreaks. This has happened for norovirus outbreaks. This has happened for other things in schools before. So yes, schools certainly has to be prepared for it, and other businesses really ought to be too, whether it's COVID or other things. This is an opportunity. We've had some, lots of bad things happen, but we've also now people who didn't think about this at all, who lead businesses that aren't in healthcare at all, have now learned, oh, this is a possibility, and oh, this is how we do this. So yeah, certainly something needs to be prepared for.
Okay. And what is the state of our public health system after this? Is the burnout rate as high as healthcare?
Emily, you probably have thoughts on this, and I certainly do.
I do have thoughts, and one of the things that I hate is that we don't know. So there has been one study from CDC that came out a number of months ago that showed that up to 50% of our public health workforce is experiencing one or more symptom of depression, anxiety, PTSD, or some other mental health condition. So they are stressed and they are struggling. We're seeing big turnover, and just anecdotally and talking with folks that I know in the system, we're seeing a lot of turnover. But it's not being studied as deeply as I think for healthcare. It's been really at the forefront of our thoughts in healthcare, particularly because there was a very public suicide early in the outbreak that showed us just how hard this is on our healthcare professionals. But the public health force is kind of behind a veil, and we don't necessarily know how much they're struggling or have good data. The suspicion is that they are. Our public health system is probably going to be struggling for a number of years to recover from this, and that's something we need to be aware of as we move forward. What I would love to see, sort of referencing the last question, is organizations taking a proactive stance on preventing disease. And so encouraging folks to work from home when they're feeling sick, encouraging them to stay home when their children are sick so that they're not spreading whatever their children might have, facilitating that through remote work, using the data to move in and out of opening and closing, and really taking what we've learned from this outbreak forward into preventing disease spread within the office environment, because our public health system is going to need that support. Right now, they're really just staying afloat, maybe even drowning. And they're going to need a number of years to restock the workforce, to get people trained, to get back to the place that they were before this outbreak hit. We're going to see a lot of mental health challenges for a number of years from this outbreak, both in healthcare and public health. And I think we as citizens can all rally around our public health workforce by doing these kinds of things proactively as businesses to take some of the weight off of our public health system. That's my personal opinion, but according to me, that's where I'd like to see us go.
Yeah, and I'll just add in just two points. I mean, from, interesting, Aveshka has a significant public health presence. I mean, we have significant public health expertise in this group, and I think we would all agree that the public health system prior to COVID was pretty backward from a technology and a resource standpoint. I mean, faxing around reports, and putting pieces of paper together, that's kind of 1980s kind of stuff, or 1970s. And so from a resource standpoint, I think we can certainly advocate for more resources from what we've learned. And then from a personal standpoint, not personal for me, but for personal for public health people. I mean, people don't go into public health to get rich. And for, you did hear stories of public health directors who were under personal threat to themselves and their families, which is ludicrous. And so, we really, we need to advocate as a group for improvements in that system.
Thank you, Till and Emily. Next question is, multiple studies from Johns Hopkins and other international organizations are showing natural immunity exists for a large portion of the population. Can you comment on any of these studies?
Well, I don't have them in front of me. I mean, there's no doubt that natural immunity to some level does exist. I mean, people do, develop that. That's the way the immune system works. But the general consensus among the really strong scientific community is that while natural immunity is part of our body's response, immunity from vaccination is really the strongest protector, personally and from a population standpoint. With really over and over this is being presented. I mean, I don't know how many times Emily has to show the slide that shows the death rate for vaccinated versus unvaccinated. It's dramatic every time you see it.
Okay, I think that's all we have in terms of questions. Any last minute thoughts, go backs, anything? Okay.
No, thank you very much, and I'm sure we'll be back. Thank you.